So, what I want to do is talk to you about a patient that came in for her second or third visit yesterday. She's a high school cross country runner and basketball player. She's, I believe, a sophomore. Um, and she originally was coming in for hip pain, hip tightness, and feeling like she was losing rotation when she got done running and feeling like her hips are tight with the completion of a cross country training or running a 5K, something like that. So she's had similar symptoms in the past, went to PT, seemed like it kind of sort of worked, but not really. She's been seeing a chiropractor more recently, kind of sort of working, but not really, and wants to see if we can give her another opinion on what's going on. So when I assessed her on her eval, she's very tall, very lean. She's probably about 5'11", and I asked mom about growth spurts. Had she'd gone through a growth spurt recently, and mom said actually she hasn't even really hit puberty yet, so that she's seeing somebody about being late to puberty. So, and mom's probably like 6'2". So when she hits puberty, it's going to be more issues with this hip thing and probably knees and all that typical stuff when you see somebody teenager with a huge growth spurt. So so when I assessed her, gait looks pretty normal, a little bit on the rigid side, toe touch limited, tight hamstrings, usual presentation for a high schooler, especially tall high schooler. Squat was tight. So when I do a regular squat, full depth, ass to grass, she complains of hip tightness. So that I said, is this the pain that you're feeling? And she said, yeah. So single leg squat, not too bad. Trunk twist, not great. So just trunk rotation, not great. Trunk extension, not too bad. And like I said, flexion was tight. And lumbar spine is tight with trunk flexion. So upper body was pretty clean, didn't do a lot there. So get to put her on the table, and the first thing I want to do with her is just see what her internal external hip rotation looks like in 90-90, comparing those sides bilaterally. And she's definitely limited with hip internal and external rotation on her left hip. Now the interesting thing is she complains about more hip tightness on the right. So get through the treatment. She's got limitations with glutes, limitations with deep hip internal external rotators. So all of gemellus, quad fem, piriformis, all those guys are inhibited. Get those back, and now her hip rotation in 90-90 for passive rotation is closer to symmetrical, but still quite not symmetrical. So get done with her, get her up, do a lot of transverse training type exercises for her to take home and use 3 to 4 times, or actually 4 to 5 times a day on her home program. She comes back for her second visit, doing better, still feels like she's getting tight at the end of a run, and mentioned something about, every once in a while I feel like I get a stitch in my side, kind of like towards the end of the run. So I go through everything we went through in the first visit, worked on many of the similar things were inhibited, so got those back going, reinforced her home exercise program. And on the second visit, I noticed she was having a harder time with glutes and glute max and hamstring. So if you want to say posterior chain, go ahead. So harder time with posterior chain than quads and abs and hip flexors, that kind of stuff. So I gave her some new exercises for her, gave her kettlebell swings and straight leg deads, RDLs. Okay. So she comes back for the third visit and was seeing our student. And I overheard her talking about mom is worried now that she's getting more of these stitches in the side, rib type cramps, and wondering what's going on. So I went over there while the student was working with her, did some Q&A with mom, asked her if she had any video of her running. So here's the whole point of what I want to talk to you about today. If you are not watching your patients do what they do when they have problems, and what they do is more than some kind of easy thing that you can see in a functional screen, then you need to see them do what they're having a problem with. So I wanted to see what she looked like running. So if you've ever, like anytime you assess gait, people just automatically change their gait because they know that you're watching you. Same thing if you watch somebody run. So I'd much rather see if mom has video of her running. And luckily she had videotape of her last track meet in the spring. So I watched that, and she had one clip where she's coming around the last straightaway, and there's a girl that's right in front of her, and then her in the trail, and she's running. And so when I was asking her, what happens when you have these stitches in the side, these rib cramps, whatever you want to call it, she said, well, it's usually towards the end of the race. Well, what do I already know about this patient? She leans towards being rigid. So she was rigid in her original screen. My inference is that as she's getting tired, she's getting even more rigid. So what do we know about joints that don't go through a full range of motion? They start to lose that range of motion. So if she's at the end of the race, she started the race rigid, she's more rigid now. Is her rib cage going to be expanding and contracting? Do you think she's having a problem with trunk rotation and using arms when she's tired? My inference is she does, and that's what's causing the problem. So we're going to check intercostals with her. But before we do that, I want to see what she looks like when she runs. So mom shows me the video, and what do you know? The good thing is the girl that was running right in front of her had fantastic form. So I could say, okay, see how the girl running next to her has a forward lean, and when she's running, you can see her trunk twist, like you can see the logo on the front of her shirt, whereas where your daughter passes the same point, all we see is just shoulders because she's not twisting, and she's really choppy and tight with her arms. So here's my inference. She's not getting transverse plane when she's running. Those ribs are getting tighter. Those intercostals are not able to expand and contract the rib cage. So she's shutting down. Okay. So as the student's going through, I see her check intercostals, and guess what? She fails intercostals on both sides. So now the important thing is, let's see what she looks like now and see what that compares to the video. So unless you're watching them do what they do when they have the problems that they're having, you're missing out on the biggest piece of information. All right, so I take her out in the parking lot and say, now here's the trick. I want you to run your normal pace without thinking about it. We're going to videotape you so we can show you what it looks like. So I said, run your normal pace. So she runs this normal pace, and it is not good. So clomp, 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 rigid, short stride. Remember, she's like 5'11", long legs. Like her legs are longer than mine. She's got these short, choppy strides. So she comes back, and I said, so is that your normal, like if you were running a 5K, that's your normal stride? She said, no, that's my normal stride at practice when we're training. Now, I'm not sure if I told you this, but she has more of these cramps now that they're doing more training than she does in season when they're doing more competing. So she just told me that she is using a choppier, slower stride in her training because it's longer distance. Now, this is what you'll get with a lot of long distance runners. They think that if they have pain or they're having problems, that they should shorten their stride and run slower. Completely ass backwards. Okay. The more choppy she is, the shorter her stride is, the slower she is on her cadence, the more she's going to pound in one plane and avoid transverse plane, and her body is going to feel it. Okay. So I told her, okay, now in the second one, run your 5K pace and let's see what that looks like. So she runs that, less rigid, better, still not a lot of arms, still not much trunk motion. And this is when she's fresh. So when she's tired, it's going to be even worse. So we were able to take the video that mom took, and I can show her, look how straight up and down you are. Look how short and choppy this is on the first video. Then on the second one, you're a little bit longer with your arm motion. You're getting a little bit of trunk motion, but you're still straight up and down. You're fighting yourself. So I told her, momentum is your friend. So the more you can let momentum carry your next stride through, the better you are. The less energy you expend, the less tired you're going to be, the less you're going to beat yourself up. So I told her, what I want you to work on is just feeling like you've got a forward lean in your run and that you're lengthening your stride so it feels like your legs are automatically turning over and your momentum is carrying you versus you powering through step after step. And see what that does for your trunk motion and see what that does for the stitch in your side. So she doesn't have any more practice this week. So I told her, okay, I want you to run on your own. And I want you to run around the block. So when you finish, you're running past mom when you're tired, and you bring me that video next time and we'll see what that looks like. Okay. So Notice I'm giving her these cues and these directions and exercises, gave her some exercises too, after the treatment. So if she would have come in and I just would have looked at that and said, oh, well, here's your problem. You need more forward lean. You need longer stride length. We're just going to give you verbal cues and tell you to do that. Remember, she was inhibited with quite a bit of stuff, and hip rotators were big, abs big, transverse abdominis inhibited, gluteus maximus inhibited. So if I would have just given her coaching tips and verbal cues and corrective exercises, it wouldn't. She would my inference, and I would bet my paycheck on this. My inference is she would have the cramps all over again, on top of having the tight hip issue. Okay, so I gave her this stuff to do after we treated her, and told her these are the things you're going to do before you run for your active dynamic warm up, and after you run, before and after you run for your active dynamic warm up and cool down. So if she just went and ran and didn't do what I gave her to help facilitate contraction and then go through a full range of motion to lengthen and open her range of motion, her joint play, whatever you want to call it, if she didn't do that before she ran, she'd still end up beating herself up. Okay, so the whole point of active and dynamic warm up is to get things facilitated with her isometrics, then go through a full range of motion to accentuate motion plus strength plus stability, which is mostrability. Never stretch, never roll, never Theragun, never do that, because that's going to cause inhibition, which would cause her to get tighter and tighter as she ran, which is what we don't want to do. Okay. Then she has to do that stuff again, because what do we know about exercise? You fatigue with exercise. Then if you fatigue, and fatigue is neuromuscular inhibition, if you let those inhibited muscles then get in a short position, so you go sit down, now they're going to spasm or cramp or get stuck in that short position. So now you're going to lose more motion. So if you can do refacilitation with your active cool down, then you head off that amount of inhibition. You might not get rid of all of it, but you're going to decrease a lot of it so you can get refacilitated with your cooldown. So then you're not playing the game where you're losing more range of motion and then you got to fight to get range of motion back. So same thing. We gave her active and dynamic warm-ups for her ribs to help kick in intercostals so she's not getting that problem. And we already gave her the hip internal external rotator isometrics and active dynamic warm-up cool down exercises. So whole point of this is make sure you're watching your patients do what they do when they're failing and having problems. So if they just talk you through it and you think they're doing one thing, but they're doing something completely different because you never saw them do it, it's going to be really hard for you to understand where their problem is, why it's happening at that angle, at that position, whether it's eccentric, concentric, isometric, whatever, what joint angle it is, what muscles are involved. You need to know all that stuff in order to zero down to the root cause. So if you've gone through mostrability, the course, mostrability, you've gone through all that stuff that I just talked about. So you should know how to screen and watch and observe and understand eccentric, concentric, what angles things are in. Now, if that doesn't make any sense, you need to get mostrability. So take that course, and that will teach you all that stuff that I just talked about. Then you can apply that to when you watch your patients run or jump or wrestle or do whatever it is they do. All right. So take home message. If you're not watching your patients do what they do when they're failing, you're missing a huge component, because you can't replicate that in a setting like this unless you have them do it.